He was the first human ever to run the mile, the regular mile, in less than 4 minutes. Okay, before he did it, it was accepted fact it's physiologically impossible for a human being to run the mile in less than 4 minutes. What's interesting is after he did it, within a year, over 100 people broke the 4-minute mile, ran the mile in less than 4 minutes. The world record now is like 3 minutes 40 some seconds. A mile in 3 minutes 48 seconds or something. It's incredible. Not the metric mile, not the 1,500 meters, the actual mile. So what changed? Where is the greatest obstacle in life? Between your ears. The greatest obstacle in life is between your ears. Okay? If you think you cannot do it, you cannot do it. If you think you can do it, you'll figure out how to do it. You'll figure out how to do it. Okay? The reason I say that is we integrate ortho into the GP and pedo practice. Okay? It's been done. I'm a general dentist in San Diego, California. I've been doing ortho 20 years, over 20 years to be 21 years now. Okay? I'm doing ortho only, I had an ortho only practice since 1996. Okay? A general dentist can do that. If you love endo, you can do 100% endo in your practice, but who's going to refer to you? That's the problem. A general dentist will not refer to another endodontist, not another GP, they'll refer to an endodontist. Okay? So that's the problem. If you love oral surgery, you can do 100% oral surgery if you want. And if you have a good enough reputation in the neighborhood, you can do that. You can do that. Right? So it's been done. Ortho in a GP pedo practice, it's being done, it's been done, it's being done. There's over 50,000 general dentists in the US doing ortho. So yeah, just get rid of the thing that that you were brainwashed in dental school. In dental school, in ortho rotation, in the written test, what was always the right answer? Clinically, this and this and this happened. What do? Refer to the orthodontist. That was always the right answer. Refer to the orthodontist. That was always the right answer. So you've been brainwashed in dental school not to do ortho. Not to do ortho. The wire bending exercise, you did it in dental school? Did you do it in dental school? Dr. Ryan, right?
Yep.
You had to bend this wire.
Yes, I did.
And we had to lay flat. Every dental school does that. Every dental school does that. Okay? University of Minnesota, UNLV, University of Illinois, every dental school, everybody I've asked, they do that. What's the whole purpose of that wire bending exercise? To frustrate you. To frustrate you. So you can't do, I can't do ortho, I can't bend. There is a teeny bit of wire bending in ortho, but with the right plier, it's so easy. We're going to do a little bit, teeny bit, not to scare you. I'm a horrible wire bender. I got a D. I had to do that 8-10 times, and the instructor felt sorry for me, passed me with a D. Okay? So if I can bend wire, you can bend wire. So there's a teeny bit, but not much. Okay? So remember Sir Roger Bannister. Remember Sir Roger Bannister. You can do it. You can do it. Yeah, welcome down. Yeah, that's good for you. All right, remember, the only stupid question is the question that is not asked, but people are afraid to look stupid. Okay? I had a doctor who emailed me months after my course. She emailed me, what is overbite, what is overjet? And she's a doctor who's been practicing longer than me. So I couldn't believe it. I had to reread it a few times, the email, and then I very diplomatically answered her question. Overbite is the amount of overlapping between the incisors. Overjet is the distance between the incisors. And I stopped, but I was tempted to ask, didn't you ask any questions in dental school? She probably didn't. She probably sat in the back, never asked a question in dental school. So if something I say is not clear, please ask. Okay? You're stupid if you don't ask. Okay? Because your neighbor probably has the same question. So you need to speak up and ask the question. Alright? I saw this quote a few weeks ago, Leonardo da Vinci, Renaissance man. Study without desire spoils the memory and retains nothing that it takes in. So you're gonna forget most of what I said. Okay? If you see a slide you like, if you feel free to take a picture of it or something, but live in the moment. Learn it right here. Okay? I've been to a concert and everybody's filming the concert. They're recording the concert. I think you're stupid. Yeah, take a selfie to show you were there, but enjoy the concert. Buy the concert DVD. If you like the group so much, they probably have a DVD. It's better than you recording the whole thing, but they're recording the whole thing. I'm like, wow. So my point is, again, learn it while you're here. Learn it while you're here, but if you see a slide, feel free to take it, picture of it, I don't mind. But like I said, learn it while learn it here. Okay? And then desire. Okay? Have that desire to really want to incorporate ortho. Then you'll remember. They'll remember. Remember, I remember very little from dental school, which is a good thing. But one of the things I remember from farm was, if you not wanna be liable for child support, remember, what interferes with oral contraceptive? The pill. Antibiotics. You better tell them you're taking oral contraceptives. Well, the antibiotic we're gonna prescribe is gonna inhibit that, decrease the efficacy. So you better use something else also, right? Or you're going to be indirectly the baby daddy here to support, right? You're going to be indirectly the baby daddy. Yeah, so remember that. Okay, so that stuck on me. I don't want to be indirectly the baby daddy. And number two, I remember patients with a history of ulcers. Don't give them what? What analgesic? Ibuprofen. It makes the ulcer worse. History. The reason I remember this, my dad has a history of ulcer. 30 years ago, he had to have surgery to close an ulcer in his stomach, duodenal ulcer. Yeah, he was in tremendous pain. My dad could take any pain, but it was doubled over. I go, this is serious. Got him to the hospital, emergency surgery for his ulcer, because the acid content was going to his, abdominal cavity. Anyways, that was 30 years ago, so he had an implant done in LA. He lives in LA. He didn't tell the doctor about the history of ulcer, gave him ibuprofen. His ulcer came back. He had to be hospitalized. Luckily, he didn't need surgery, but it was small enough. They just get acid blockers and that. But yeah. So again, you remember what is applicable to you. That's my point. You remember what is applicable. So have a desire to retain this. Okay. Have a desire to retain this. I'll ask you the important points. I'm gonna go over and over again. Until I hear you just answer really quick, then I know you got it. But have a desire to retain this, okay? Remember, the Chinese philosopher Confucius says, I hear, I forget. You're gonna forget 90% of what you hear at this course, okay? The only thing you'll remember is maybe I'll tell you some jokes. Maybe you'll remember the jokes. They make you laugh, maybe hopefully make you laugh. But anyways, you forget 90% of what. You forget 90% of what you hear. Your significant other, if it's male, they forget 100% of what you say. Your husband doesn't retain anything. Okay, doesn't retain anything. Okay, you see, I remember. I'm going to show you a lot of cases. I'm going to show you a lot of cases, and then there is some homework for you to do. Putting on the donuts, E-chains, open coils, little teeny bit of wire bending. You have to practice. You have to practice. All right, you have to practice. Remember, there is a learning curve. 4-hour buckle pits in private practice, that doesn't cut it. You should take a few seconds. Done. Have the assistant finish it off. EF assistant finish it off, whatever. Extend the function assistant. All right. So orthodontic philosophy. So this is that overview of where I'm coming from. So a little review. Some of you saw at the intro course, but this goes a little more detail. So ortho philosophy. So number one, I want the face and the profile. We want to make our patients look better from the front and from the side. Okay, if there was one word that describes, that makes a face attractive, what is that one word? Here's the hint. Look at her face. She is symmetrical. Our goal is to make the face symmetrical. We cannot attain this because most people are symmetrical or asymmetrical? Asymmetrical. Never ever promise the midlines to be right on the money. You won't. Most people, the midlines are. Raise your hand if your midlines right on the money. Upper and lower midline. Nobody? See, and you guys are all in the dental field. Okay? So the normal is upper and lower midline not lining up is normal if you go by the population. Because most people are slightly asymmetrical. It doesn't line up perfectly. But that's what we're trying to restore. But this is fantasy land. This is not real. To make this, you need plastic surgery or a lot of Photoshop. That's it. A lot of Photoshop or plastic surgery. Okay, but we're trying to restore symmetry. Okay, what is this line called from the nose to the chin? What is that line called? The aesthetics line. The lips should be to that line or a little bit in front of it for a nice profile. And there's ethnicity involved. Asians, African Americans, Hispanic, we're fuller, right? Caucasians, a little more straighter, okay? But we want the lips to be full. Name the actress. Angelina Jolie, Mrs. Brad Pitt. Look at her full lips. Look at her teeth. Are they protrusive or retrusive? Retrusive? Protrusive. Yeah, sorry. Earwax. Yeah. Protrusive. Protrusive. Okay? A little bit protrusive is more attractive than retrusive. Fuller smile is more attractive than retrusive. Okay, remember Angelina Jolie. Another star, she's on the HBO show Shameless. Emmy Rosa. Okay, very full. Alice Eve from Star Trek a few movies ago. That's full teeth. Very full. And, well, how about the small smile? Well, the small smiles, when they're in their teens or early 20s, cute. Small little smile. As they get older, man, they get old fast. All the wrinkles come out fast. Which teeth are missing right here? The bicuspids are missing. Usually when there's crowding in the front, in dentistry, in orthodontics, which teeth do they pull? First bicuspid. And they do bad ortho mechanics. Look at that. Yes, the teeth are straight, but look at the teeth. Are they proclined or retroclined? Retroclined. Look at the loss of attachment, because when you retrocline, the roots go which way? Forward. So you lose attachment. Okay, retrocline. This is not good ortho. This is bad, like this. Okay, look at her profile. Is she concave, caved in, or is she full, convex? She's caved in. Why? She's missing premolars, and they pulled back everything. So she looks a lot older than she is. Here's a young patient, 16 years old. Okay, he's crowded. Based on his profile, is he an extraction case or a non-extraction case? Non-extraction. When you have a patient that's concave, crooked teeth, but concave, don't extract. Because as you get the teeth straight, we're going to make his profile fuller. That's what's supposed to happen. Is that logical? Yes. But no, the doctor, oh, it's too crowded. Just look at the teeth. Dental school, we zone in on the teeth. Okay? So they pulled bicuspids on him. So this is what he looks like now, at age 18. Look at that, looks like an old man. Yeah, in my younger days, man, he looks 40. Now, 40 is still young. 40 is the new 30. So, he looks 60. To make it older than it is. Yeah, he looks like a real old dude. 60, 70. He looks a lot older than he is. Look at that. He's only 18. Now look at that. Look at the face. Okay? So Compendium magazine still around. I still get Compendium sometimes. On an article, abstract, modern aesthetics dentists realize the facial soft tissues serve as a frame for the restorative artwork. The soft tissue is a frame for your restorative artwork, right? As we get older, what happens to vertical dimension, VDO? What happens as we get older? Decreases. Look at that. Decreases. Decreases. Okay? The function of teeth, the number one function is not chewing. Is a paradigm shift here. Okay? I examined two of my a side gig. It's just a fun side gig. It pays very little, but I do it as a service in California. Yeah, it doesn't apply to you guys. You guys are California dentists, but I am the screener, the clinical screener for DentiCal. So all the complaints, I see them. They usually is endo and dentures. So I screen them. I'm the police, the internal affairs. I look at it. Oh, you know, approve the endo or not approve it or that. So I'm the screener. So I saw two edentulous patients 2 days ago. Dentures. I'm like, oh my goodness. The ridges were good. The dentures were too much video. A patient can. No, that video, so I had to check, not acceptable, too much. Post-palatal seal, there wasn't any. The doctor was a rush job, so I had to, I'm the internal affairs for dentures. But what was interesting to me, I asked the patient, it was immediate dentures from 6-8 months ago. They're not dead from malnutrition. Without teeth, they haven't been wearing any teeth for 6-8 months. Are they dead from malnutrition? No. Are they gumming the teeth, the food to death? So the main purpose of teeth, you can live without teeth. You can live without teeth. It's not ideal, but you can live without teeth. The main purpose of teeth is to hold the skeleton. You hold the upper and lower jaw relationship, which then affects the muscles, which then affects the airway. To open the airway, the jaw has to be back or forward. How do you open the airway? Forward. That's the purpose of the teeth, is to hold the jaw forward. If the bite is right, is to hold the jaw forward. So the teeth is not mainly for chewing. Okay? Let me prove that to you also. You know how the research shows bite of food, how often you're supposed to chew? How many times you're supposed to chew? 20. I counted. I do maybe 3. Swallow. I eat too fast. To chew 20 times is very hard. It's very hard. But you're supposed to do 20. I do 3, 4. That's why teeth is not the most. Chewing is not the main function of teeth. It's not. It's to hold the airway up. So here, suck out the fat, inject it into the face. So she has more support. She looks younger. So they took the fat from her abdomen, looks like, injected to her face. More aggressive, lip implant. Lip implant, Avanta lip implant. Thread that to the upper lip. Okay? The price of beauty, look at that. Less wrinkles. Less wrinkles. More support. Okay? Teeth is to support the soft tissue. Okay? Support the soft tissue. Alright? Now TMJ, dental school, Dr. Ryan, CRCO, are they still teaching centric occlusion, centric relation?
Yes.
Yes? How did you take a denture bite? How did they teach you to take a denture? On an edentulous patient, a bite registration on an edentulous patient.
You had to make bite rims and usually use Alliwax and you put them in the most anterior superior position.
Anterior superior. I mean, so how they taught me in dental school was have the patient put the tongue to the roof of the mouth,
Yep.
and then shove it back.
Mm-hmm.
And then you take the bite there, right?
Yep.
Okay, and then this is what happened. I'll do the dentures made, deliver the dentures. I did beautiful job, fenestration, buccal roll, all the anatomy. I want to pass this dent. I want to get out of pros, right? So I deliver it, and the patient puts it, and they bite down for me. You know how they do it? They go right good.
Yes.
Yeah.
Yeah.
No. Hold it back. But dog, it hurts when I hold it back here. Hold it back there. The teacher's coming. I need to pass. Hold it back here. And tell him it feels good. I'll give you $100. I need to get out of this hellhole. Right? It made no sense to me. So last course in Chicago, this one dental student went to University of Illinois. He goes, how they taught us was where it feels good to the patient. Well, I go, that's a progressive dental school. Where it feels good to the patient.
Just a
That's-
swallow and bite.
I'm sorry?
Swallow and bite.
Yeah, swallow a bite. Yeah, swallow bite. Yeah, there we go.
Bite.
Where it feels good to the patient, see? But the doctors graduated last year. That's why they're still teaching it.
Oh, yeah.
It's wrong.
Yeah.
It's absolutely wrong. It's absolutely wrong.
Shoving their mandible back in.
Yeah. Yeah. Look up the definition. Google centric relation. ADA now is down and forward.
No.
Up and back. It's down and forward now. ADA. Hope it stays there. They keep going up and back, down and forward, up and back, down and forward. Lately, but I haven't checked in a few months, was down and forward. Down and forward, where it feels good. Swallow bite. The swallow bite. Yeah, that's a good one. Alright? So this is an MRI of a spine. The whole thing is get everything aligned. This has to be aligned. It affects the whole body. Alright? There's 3 O's you're going to be learning at this course. 3 O's. The first O is easy, the teeth. Ortho, straight teeth. Ortho, Donics, okay? Straight teeth. Ortho means straight, Donics teeth, straight teeth. Number 2, bone. Ortho, pedics. We'll talk about palatal expanders tomorrow. Chris, sorry, I mean, I stuck on Mike. Chris is here with the lab, so he has a lot of sample appliances. There's tons of palatal expanders. Okay, so we'll talk about palatal expanders tomorrow, and get to know Chris, the lab services. Ollendorf is a great lab, and Mike is here for supplies. So braces, wires, and all that. They're all tools to get the job done. So orthodontics, orthopedics. The third O, which probably most of you are not familiar with, is orthotropics. Talking about airway, thumb sucking, tongue thrust, speech pathology. Okay? If you have a thumb sucker, oh my God, you're gonna have a class 2 div 1, flared upper teeth, because the forces are not balanced. Okay? The thumb pressure overcomes the orbicularis oris, the lip pressure. So you have this bug teeth. If you have a tongue thruster, you're gonna have an anterior open bite. So that's all orthotropics. So we need to address the orthotropics, okay? Orthopedics, bone, and teeth is orthodontics. All right, we want to balance all that. Those three things, we want to balance it out. Balance it out. Okay? Orthotropics, that's the one probably new to a lot of you. Okay, we're going to balance it all out. All right, here we go. Everybody's good. Everybody's engaged. Okay, diagnosis. Look at the upper incisors. Are they proclined or retroclined? Retro. Retroclined. Look at the fractures. Look at the chip here. Okay. Yes. No anatomy on that bridge. Mercury alloys. Yuck. But look at all that. Do you think she has a deep bite or open bite? Deep. Look at that. The roller coaster bite. Okay. What did they teach us in dental school? You make it to the existing bite. Because when she bites down, the occlusion looks pretty okay. Look at the intercuspation. Looks pretty okay. But look at the front. Okay. One thing I never understood in dental school until I got out into private practice was the envelopal function. Does that ring a bell, Dr. Ryan? Envelopal function?
Yep.
What the hell are they talking about? Envelopal function. Okay, this looks like an envelope, I guess. I didn't understand what the hell they're talking about. But I knew how to answer, to pass the test. But I still don't understand what the hell they're talking about. So what they're talking about is this. I learned the hard way. Okay? Big veneer case. To do veneers really cosmetic is first bite, not just canine to canine. You need to go to the first bite, right? To really do it nice. Patient willing to pay, want a nice smile, did the veneers. The problem is, I did the veneers on abfracted teeth. There was all these abfractions. Did they teach you abfractions in dental school?
Yes.
Okay, well, you know what they taught me in dental school 25 years ago? What those grooves were? Anybody know? Toothbrush abrasion. That's what they taught it was toothbrush abrasion. Okay, patients were brushing with diamond bristle toothbrushes and putting all these grooves. That's what they taught us in dental school. But abfraction, how do you know? So I put veneers. Patient is crying, so happy, so beautiful. Okay, 2 weeks later, phone call. What does the phone call say? What did the patient say? They're breaking off. They're breaking off. I'm like, what a nightmare. Because the envelopal function was not there. This is the envelopal function. The patient was every time opening, she was bam, bam, bam. It cannot withstand that. It was all breaking. Or if you do PFMs, what happens? Lower incisors, completely worn. The patient is doing equilibration themselves. The envelopal function. It's supposed to be like this, not like this. Tomorrow we're going to do ceph tracings. You need to have a basic understanding of cephs. So we'll talk about angles. The proper angle between the upper incisors is supposed to be 130 degrees, not 180. If it's 180, this is 180, a straight line. There's no function. There's no envelopal function. You have abfractions. If it's like this, there is no anterior misguidance. That's what we're going to do. Torque out the teeth. Proper torque. You'll learn how to do that at this class. Also, every patient have them fill out a TMJ questionnaire. It's page 2 in your handouts. Okay, handout. Who else didn't get a handout? Anybody? Yeah, page 2 of the handout is the TMJ questionnaire. Have every patient fill out a TMJ questionnaire. And if you think, oh, I don't have any TMJ patients in my practice. Well, if you don't know how to diagnose caries, let's say you don't know how to diagnose caries. You have 0 caries patients in your practice. If you don't know how to diagnose caries, you have 0 caries. Your patients have 0 caries because you can't find it. So you need to, you have TMD patients. You just don't know it. Do they have ringing in the ears, headache, muscle tenderness, grinding, popping, clicking? These are all symptoms of TMD, temporomandibular disorder. So have them fill that out too. You need to diagnose any pre-existing condition that they may have, predisposition to getting the TMJ worse, okay? TMD is real. There's a delicate balance, teeth, bone, muscle, blood vessels, and nerves. This has to be all balanced. The stomatognathing system has to be all balanced. There you go, there's a big word for you, right? So here's the relationship between occlusion and the TMJ. What happens here? The teeth are connected to body of the mandible, and the condyle is connected to the body here. What happens here affects here. Affects the condyle. We don't want to be up and back. Centric relation, no. We want to be down and forward a little bit in space. The ideal condylar position, Dr. Harold Gelb, Mike, he's still alive, right? Yeah, Dr. Gelb, I think he's still alive. He's up there in age, but he defined it as the 4-7 position. So he drew this grid, 1, 2, 3, 4, 5, 6, 7, 8. Most of the condyle should be where? 4-7 position. That's normal condylar position like this. That's normal. That's where the condyle should be. Dr. Gelb's 4-7 position. So what's normal condylar position? The Gelb 4-7. How do we check? Radiographically. So in the olden days you have transcranial tomograms. Now we have cone beam 3D imaging. Okay, send them to the X-ray lab, unless you want to spend the big bucks and get those machines. But you have the cone beam technology and 3D imaging technology to see exactly where the condyle is. But back in the day, it was just transcranials and tomograms, just 2-dimension. Now we can see 3D where the condyle is and the shape of it. All right? So this is bad. This is good. Minimum, how many millimeters do we need retro to the condyle? How many millimeters minimum? 3 millimeters. Minimum 3 millimeters retrocondylar space. Alright? So question. What happens to the condylar position as the VDO is lost? As you lose vertical dimension, which way does the condyle go? Up and back. Up and back. This patient, because she has no anterior stop. Look at her teeth. What's her interincisal angle? 180. So there's no anterior stop. He's going like this. She's wearing out her teeth, breaking her teeth because she has no envelopal function. The condyle is going back and she's dying. I know it's not PC, dental cripple, but that's her word. I feel like a dental cripple, she said. She had an MRI, the CT scan done of her brain because she thought she had a brain tumor. Severe migraines, okay? And there's a difference between a headache and a migraine. Anybody have a migraine headache? Okay? A headache, take some Tylenol. Unless you have an ulcer, you can take some ibuprofen, analgesic, okay? And then the headache goes away. You feel better. A migraine, you're bedridden in the fetal position, like kill me now. You cannot function. You're light sensitive. No, you want to die. You want to die. It's not just a headache. You're in the fetal position, just like wishing for death. That's how bad it is. That's how bad it is. A lot of migraine sufferers. TMD is growing. Super Bowl. Did you get Terrell Davis, Denver Bronco, few Super Bowls ago? And after halftime, like, where did he go? He's the running back. He was having the migraines. Terrell Davis was, during the Super Bowl, he was having migraines. You think, suck it up, get out there. He couldn't. Big, strong guy, he couldn't. And then he got braces after. Brett Favre, they did braces on him. But he went to the wrong ortho. He pulled bicuspids. You see Brett Favre? He pulled bicuspids on him. They just made it worse. The wrong ortho guy. Brett Favre, horrible. He has giant gaps now right here because the side reopened because the tongue pushed out, and so he is He's missing bicuspids. Brett Favre, look at it. Alright? So I got this from a textbook, a presentation, doctor showing off his cosmetics. I go, oh, it's not natural looking. Nobody should say, wow, nice crowns. They should say, wow, nice smile. They should not be able to tell their crowns if you're really good, right? But look at the video, deep or open? Very deep. TMJ health, probably not good. Does the patient have envelopal function? No. They're gonna wear out their lower incisors like crazy. Either break the porcelain or most likely wear out their lower incisors. The lower incisors are gonna be gone because they're gonna be just rubbing. No envelopal function. So what they should have done is, yes, of course, treat the pathology. You have to take care of the caries. Clean it up. I would have just done a composite if possible, temporize it, and then ortho, open the bite, torque out the teeth for the envelope, restore envelopal function, then do the crowns. Okay? This is an orthotic. This is a splint, orthotic. It's just like a band-aid to determine where do they feel good. Where does the vertical feel good? You can add acrylic, you can remove acrylic. So talk to Ollendorf Laugh about the different splints that they make. Orthotic is more elegant than just saying splint. But Ollendorf, yeah, orthotic, you can charge more for an orthotic. A splint, oh, just a splint. But there's different orthotics to open the vertical, determine. Then the patient, 4 to 6 months, they feel better. Maybe not 100% better, but 90% better improvement. Then you either prosthodontically or orthodontically build them to that new vertical. If they have a lot of existing crown and bridge, then you replace it. They need to spend some big money to do that, but now they're willing to because they feel better. Oh my God, I want my bite here. I want to graduate from the orthotics, so they do that. Or orthodontically, you move them to the new bite. You change them to the new bite. Adult ortho is growing. I had a patient, class 2, div 2, lower incisors worn. She has severe pain and she's a speaker. She has to pop the pills, migraine medicine and all that. Imitrex, that was one of the standards for migraines, Imitrex. But I said, well, your cause is, I'm pretty sure, it's your deep bite. You're overclosed, you're wearing out your teeth like crazy. So pain is the motivator. So we're doing ortho to torque out the teeth and to open the bite. Torque out the teeth and open the bite. Okay? So, she's motivated to do that. It's not just for cosmetic. So the modern 21st century dental medicine treatment plan, treat the urgent pathology. Dental school teaches how to do that. Dental school, do they use caries disclosing solution?
Not at my school, no.
Not at your school. You just explore?
Yeah.
Wow. Okay. Caries disclosing solution. Good stuff. Anybody use Diagnodent?
Our school was against it.
Against it? Okay.
Yeah, we had a big speech about how it's
It's not
shouldn't
good.
use that,
Diagnodent
yeah.
is not good. I don't know. I don't think it's definitive, but it helps. Because my partner, what they do, the Diagnodent, was for co-diagnosis, patient hears the beep, whatever. Oh shoot! So again, the caries. They hear the thing, whatever. But anyways, detect the caries, clean it out. Then you're here to neuromuscular, dental skeletal, physiologic balance. Restore envelope of function. Restore proper bite, okay, or close to it, and then do the extreme makeover. Okay, remember it's more than a few years ago now, that extreme makeover, the human version, now they have extreme makeover home version. They get houses, basically almost tear it down and build a new house. It's just gorgeous and people cry, it's so beautiful. They used to have a human body, they get all these ugly ducklings, liposuction, teach them exercise, diet, and then plastic surgery, and then the cosmetic dentist on the show. Who was the cosmetic dentist on the show? He used to own Discus Dental, Zoom Whitening. He sold it for millions. Anybody know? Bill Dorfman. Dr. Bill Dorfman from Beverly Hills, the Beverly Hills dentist. One of the reasons they canceled the show was lawsuits. Some medical complications, one. Dental complications. You know what the dental complications were? Porcelain breaking off. He would do beautiful veneers or PF crowns, I'm thinking that's not gonna work. They're overclosed, but it's beautiful. But porcelain could not withstand the bite. You know, maybe he was giving him a night guard or anterior nighttime appliance or something. But patients don't want to wear those things, and they were breaking off the porcelain. So all these lawsuits, they had to quit the show. They had to quit the show. They had to cancel. That's why they canceled the show. You know, all these lawsuits happening. One is dental, and there were some medical complications too. You know, so because it's pretty aggressive medical procedures. But anyways, you're here to do. I'll teach you how to do this to establish proper bite, video, envelopal function, and all that. More than just straightening the teeth out. Remember CRCO. How do you do CR if the condyle is half gone? Degenerated condyle is beaking, and you still shove them back there. Occlusion, centric occlusion. What if all the cuts are gone? Where do you put what? Makes no sense. You have to have pristine condyles, pristine teeth to do CRCO. Who does an ideal class 2 prep? They still taught ideal class 2 preps?
Yep.
Yeah, because you have to know how to use amalgam. They still use amalgam in some parts of the country or parts of the world. Amalgam, sometimes you still have to use it, right? But now in the 21st century, we have those flowable composites. You don't have to be so aggressive in the preps. You just air abrasion, some of them occlusion, air abrasion, or a lot smaller preps because we have the flowable composites. I just had my old mercury alloy replaced, number 3. Oh my gosh, so much better. No sensitivity, no heat expansion, the flowable composites. Yeah, so this is, all due respect to Dr. Black, you're passé. He didn't have the materials we have today. All right? So my thing on on occlusion is the physiology detects the occlusion. Where does the patient feel good? Where does the patient feel good? Don't go by the teeth. Teeth is just a little reference point, but it's not the reference point. You can do a perfect class 1 occlusion. Perfect. Overbite, overjet, proper torque. Visually perfect. And the patient, genetically, they're class 3. Genetically, they're supposed to be here. The jaw genetically is supposed to be here. And you put them class 1. They're going to have severe pain. But doc, I feel better here. Because they're genetically class 3. Alright? So that's not good. Don't go all, my point again is the teeth are a reference, but they're not the absolute guide. You can move teeth. You can move teeth. I do a lot of class 3s because in Asians there's class 3s. So the normal bite, what was the interincisal angle, remember? 130. It's supposed to be like this. Asians, I hardly ever finish like this. Asians, I finish like this and like this. Upper teeth more proclined, lower teeth retroclined. That's normal for Asians. Like this and like this. That's how I finish. I don't finish like this. I finish like this in Asians. That's the limitation. We'll talk about that tomorrow when we do SEFs. Because A point right here is back on Asians, so I have to finish more protrusive. So I have to study the face. Alright, so that's a big thing on occlusion. Airway. Airway. I got this from the ENT journal. Okay? These are your grade tonsils. Grade 4, tonsils extend to the midline. Grade 4 tonsils. Grade 3, tonsils are beyond the pillars. You can read this for yourself. Just Google it. 0, tonsils are removed. This is how you grade tonsils, okay? So what grade are these tonsils? 4, 3.5, 4, almost right to the midline. 4. Those are huge tonsils there. Okay? Send them to the X-ray lab. Chicago being a big city, dental X-ray lab. In San Diego, lateral skull, a Ceph X-ray. They charge $75, $80, 75 to $80. Not very much. The patient pays. They pay out of pocket, and if you want to help them out, we'll bill their insurance and see if they get reimbursed. But they have to pay out of pocket. We can't be waiting for insurance forever, you know. We just have to pay $80. Come on, it's not $800. We want to pay, and this is what you see. What is this blob right here? We just saw it. Tonsils. What is that right here? The adenoids, the palatine tonsils. Okay. This is Chicago during rush hour. It goes to 4 lanes to half a lane. Nothing's moving, just congested. All right. This is Chicago, no rush hour, wide open. You see the difference? Tonsils, adenoids removed. This is the same patient right here after tonsil adenoid surgery, age 7. Okay, this is actually my son, my second son when he was 7. Why did I have his tonsils adenoids removed? It's a 1 hour outpatient surgery, not including the pre-op. Pre-op, anesthesia, it's about an hour of the pre-op. The actual procedure is an hour, and then another hour and a half recovery, and then they don't hospitalize them, they send them home. Unless there's complications, then they hospitalize them. So yeah, it is surgery, but we did it, why? He looked like this, he had this like this, he had this venous pooling. That's not my son, but anyways, to show you venous pooling. That's venous pooling. See the black circles under the eyes? The kid was not, my son was just tired all the time. He was like, oh my God, didn't you sleep? Have you been checking your smartphone under the covers or the iPad or what? What? We make sure they got good 8 hours of sleep, 9 hours of sleep. Okay? But he was always tired. Venous pooling. His brain wasn't getting oxygen. Allergic salute, just consent. He got my allergies. He got tonsillitis, clavicular tonsillitis. Food would get stuck in the crevices of the tonsils. That's yeast, remember? Candida albicans, remember microbiology, Candida albicans, right? So here's the ENT Associate of San Diego letter thanking me. Upper airway obstruction, secondary adenotonsillar hypertrophy, affecting, can somebody read that? Affecting what? Orthognathic development. Orthognathic development is our field. Dental medicine, orthognathic development is our field. Airway is our field. Dentists are not limited to teeth. Orthognathic development, airway is our field. So here's an ENT, MD, thanking me. Sheriff Keria will proceed with tonsillectomy, adenoidectomy. He agreed with my diagnosis. So the first page of your handout, I think, or the second page, here's the form ENT letter. Okay, dear Dr. MD, please evaluate the tonsils, adenoids affecting orthognathic development, blah blah blah. All the customize this form. Okay. Also, I think a lot of you, I emailed you the forms already. But if you didn't get these forms by email, email me, ask me for my forms. My secretary will email you the forms, so you don't have to retype all this. You have the word processor, just customize it to your office, so you have it. Okay, so if you didn't receive it, email my office, drsong@jinsongdds.com. It's on my card, and we'll email you the form so that you don't have to retype everything. Just customize it to your office. You have Microsoft Word. If you don't have Microsoft Word, go to the internet and download OpenOffice. It's free. Actually, it's easier to use than Microsoft Word, and it opens all the Microsoft programs. OpenOffice. Just Google it, OpenOffice. It's a great program, and it's free. Price is right. So, anyways, so to the ENT, we send them this letter. There's 3 things to do for referral, because it's really hard. Okay, with HMO, Obamacare, all that red tape in medicine, it's gotten really hard for tonsils to get it removal. So there's this letter. Okay. Number 2, a copy of the X-ray. Letter, copy of the X-ray, and number 3, get the parents totally believing in this. If the parents, they go look at you like, you're a dentist. How come you're talking to us about airways? If they're very skeptical, like they're looking at you like, do you know what you're talking about? Then you have no credibility, they're not going to do anything. But if you show them, this is your child's supposed to look like this. See the airways, mom and dad here and here? Just compare that. Does your child snore at night, or do they have night sweats? Even though it's not hot, they have sweating. See, they're struggling to breathe. Do they wet the bed? Do they grind their teeth? That's because the brain's not getting oxygen. Okay? Brain's not getting oxygen. Do you want to test it? Go to the pediatrician, ENT, do a pulse oximeter, see how much oxygen they're getting when they're sleeping. A sleep study. the oxygenation, they can monitor the oxygenation of the REM sleep. Or, you know, the wave, they cook them up. Are they going into REM sleep? They're not, because the body's in stress without oxygen. Try to breathe with a pillow on your face. It might be your wife trying to kill you. It's okay. all right. You can't get a good REM sleep. Okay, so the three things are a copy of the lateral skull, the ENT referral letter, and most importantly, get the parents involved. Get the parents really invested in this, that this is important, okay? I have family ENT, Dr. Kingsley Chin, Atlanta, Georgia, ENT surgeon, allergy specialist. Okay, my friend who's like a big brother to me, Dr. Jay Lee, LA, ENT surgeon doctor. I asked him, how come it's so hard to do it? Insurance companies, you know how much they want to pay for an ENT surgeon to the physician? The analogy is this. Would you do a crown for $50? HMO crown. $50 copay. $50 for a crown. You're smiling. There's no freaking way. You lose money if you do a crown for $50, right? The ENT surgeon, they reimburse $300. $300 for all the liability of the surgery? There's just no way. There's just no way. So the insurance company protocol is they come, just give them allergy medicine. They'll approve the allergy medicine, the asthma medicine, but not the surgery. The insurance company doesn't want to pay. This is the truth. I'm getting it from family members who are in the field, ENT doctors. Alright? So it's really, really hard. The parents have to fight their way through the red tape to get it done. For my son, here, this is my son. How I did it was, I was paying the extra money so that I don't have to go to the gatekeeper, the family practice doc or the pediatrician. I found the ENT, hey, Jay, you have a good referral colleague in San Diego that you know of, good reputation. He gave me a couple of names. I went right, made an appointment, went right to the doctor because I'm paying